So I'm just gonna share my screen before I introduce him. Okay, so Dr. Nortin Hadler is a physician and medical researcher who received undergraduate education from Yale University and medical education and training from Harvard University. Further training includes institutions such as Massachusetts General Hospital, National Institutes of Health, and the Clinical Research Center in London. Until 2015, Dr. Hadler worked as the attending rheumatologist at the University of North Carolina, Chapel Hill, where he eventually reached mastership in the American College of Physicians and the American College of Rheumatology. Dr. Hadler's focus on basic biology and what he termed as industrial rheumatology led him to become an established investigator of the American Heart Association and earned him membership in the American Society for Clinical Investigation. Dr. Hadler has produced over 200 papers and 12 books, which receive recognition for his analysis of the illness of work capacity. Dr. Hadler continues to serve as professor, author, and researcher today with a growing passion for workplace health and safety, as well as health policy. Dr. Hadler also served as an attending physician at Georgetown Medical Service between the years of 1970 and 1972. So I'm going to let Dr. Hadler take it away.
Well, thank you. That's all very kind of you, but the last comment is very important to me. From 70 to 72, I was a clinical associate at the National Institutes of Health. We called ourselves the Yellow Berets. We were serving our draft commitment as researchers, and it's a very famous program. It's led to a tremendous number of professorships in medical schools and a lot of Nobel Prizes. But I'm a congenital clinician, and while I was working up in Bethesda, I was missing the bedside and the bedside clinical exposure and the bedside education. And Georgetown kindly let some of us come down from the NIH to attend on the general medicine service, which in the early 70s at Georgetown was an exceedingly exciting place. It was Proctor Harvey was the cardiologist, Nate Zweifler was the rheumatologist. These were people who were tying the bow on a era in medical research that led the way to everything we think of in medical research today. They were describing diseases and describing their ramifications, and it was a pleasure to teach in that environment. Georgetown was a leader in the early 70s in the care of the patient and the definition of clinical illness. But I went back to the NIH and back to Boston and back to my career path, which was heavily oriented toward basic science. And my problem was the disconnect between life in the laboratory and life at the bedside. And as that disconnect grew through the 70s and into the 80s, I began to realize that teaching at the bedside was not getting easier, it was getting harder because we were dealing with a lot of cognitive dissonance. And that notion led to, can I have the next slide, led to a paper in, actually in the 80s when I first started writing about this, in this paper in the 90s, which is titled The 4 Laws of Therapeutic Dynamics. And it occurred to me that we were losing sight of why we went to the bedside and why any human being would ever choose to be a patient. And I wrote these 4 laws, which have helped me structure some of my thinking ever since. So the first law of therapeutic dynamics is that the death rate is 1 per person. The second law is never poke a skunk. The third is there has never been a quack without a theory. And the fourth I borrowed from Robespierre, that institutions die, it's the people that live. And those 4 laws need to be remembered, I think, by every one of the graduate students in this program when they start to think about health policy, and by all of us who might have reason to interact with the modern healthcare delivery system. And we all seem to have reason to interact because the best estimations say that at any given moment, about half of us are either practitioners, or patients, or both. Now, I'd like to structure the comments I make in the next 45 minutes or so around these four laws, starting with the first. And the best way to start with the first, you can have the next slide, please, is with these set of curves. Remember, the first law is the death rate is 1 per person. It occurred to me a long time ago that I didn't really care what killed me as much as I cared when. And the when is a moving target. And that's what these curves are. You're looking at the percentage of the American population that's surviving as a function of age through the 20th century. And at the start of the 20th century, what you see is a tremendous amount of infant mortality, so that the average age of death was around 50, which is what it had been for quite a while. In fact, Bismarck, when he signed off on the Prussian notion of social legislation, was clever to pick 65 as the age of retirement, because back then, not a lot of people made it to 65. At the turn of the last century, a fair percentage made it to 65, but you were getting old at 65, and you were certainly getting. And what happened through the century is this family of curves. The notion that you would live forever has to be tossed, that Ponce de Leon kind of notion. There seems to be a finite longevity for our species, just as for every other species. What happened over the century is the likelihood that you would be an octogenarian increased decade by decade. So that by the start of the 21st century, we were approaching the ideal curve. The ideal curve has all of us happily living to about 85, and that's it. As I like to teach, if you're feeling well at 85, you're off warranty. And it actually turns out to be true. So the likelihood of getting to be a nonagenarian has not increased. It's the likelihood of getting to be an octogenarian, of making it to 85, that has increased. This has tremendous ramifications for a lot of what we think about as health care and health and disease. It also has ramifications for why did we do so well. Now, I can easily explain the infant mortality part, in part, because of hygiene and sewers and water, safe water and the like, that really starts to come into play in the early part of the 20th century. But once we have a country like ours, a resource advantaged country, which I define as it's safe to drink the water, there's a whole set of definitions about how do you define a so-called advanced country. If we compare ours to other resource advantaged countries, we learn that we're actually lagging most of them, but they're all doing this. They're all having this set of curves that are pretty rectilinear. And the number of folks who are taking credit for this is enormous. And leading the bandwagon is the healthcare delivery system. Can I have the next slide? It is such a prominent part of our daily life that I wrote this for Scientific American about a decade ago. The 4 laws were about 25 years ago. Today, health is a commodity, disease is a product line, and physicians are a sales force in the employ of a predatory enterprise. And the reason most people think this is probably okay is that set of curves that said, wow, look how much we've accomplished. And if I were to change this imprecation today, I get rid of today as the first word and substitute always. Can I have the next slide? Some of you know the history of Asclepius and Greek medicine. It's fascinating. It's fascinating and it's relevant. Asclepius was the son of Zeus, and he had 5 daughters, and he immediately realized that he needed to do a healthcare delivery system for antiquity. And he assigned to each of the daughters a role, a product line. And he actually had a series of clinics called Escalapians all over the ancient world, where you could go for the ministrations of his 5 daughters. He had 3 sons, but they were less involved in this. More important than that, he was the first CEO of a large healthcare delivery system, sort of reminiscent of CVS, is the fact that there was a set of rules on how you took care of people and how you advanced health care. And those rules were all inductive reasoning. Can I have the next slide? For Aesculapius and the director of one of the Aesculapians, Hippocrates, and most of his company, the theories he declared, or they declared, were considered compelling and sacrosanct. Anybody who wanted to test those theories were considered empirics, and empirics was a synonym for a charlatan. So untestable, untested, and otherwise untenable theories were the rule in antiquity and abound in modern dress. And that's where we're going today. Can I have the next slide? There was an iconoclast, one of my favorite iconoclasts, and that was Prometheus. And he thought Zeus had no right to control fire, which was considered the secret to creative thinking and to a nurturing civilization. So he stole the fire from Zeus, for which he was punished. And the punishment was he was chained to a rock, and an eagle was brought to chew on his liver every day, and it would grow back the next day. Interesting bit of molecular biology. And so the message was, don't you dare question the dogmatists. They were truth. Can I have the next slide? So we're back to this family of curves, and we're all taking credit for it. We all being the healthcare delivery system, because it seemed obvious. I mean, what else was going on that could possibly account for this? But for a long time, we've known that looking at data like this and inferring the causal events was a dicey thing to do. And we particularly knew that about these curves. Can I have the next slide? So most of us would be talking about all the great advances in healthcare delivery and science that went on between 1900 and the 1970s. But it turns out that most of the improvement in longevity happened before most of the major advances that went. That doesn't mean they're not advances, they're advances. But this population improvement in longevity, the fact that you were getting closer and closer to going off warranty, had very little to do with all of these advances. There had to be some other explanation. And the other explanation becomes apparent with the next slide, but I'm going to pause here for a moment to make sure you realize that once we cleaned up the environment in terms of hygiene, in terms of safe water and sewers, these other epidemic diseases that we treat and have to treat and should treat and can treat were far less frequent and far less a public health menace than they had been at the turn of the century. Can I have the next slide? Thanks. This is one of many such slides. This is one of the early ones. What you're looking at is the longevity of various populations. Here it's defined as our states and the Canadian provinces. And what you learn is that they're not the same. The chances of surviving longer vary depending on which state you live in. And in fact, if you live in the northern Midwest states, you might live as long as they do in the Canadian provinces. And the x-axis here is longevity. The y-axis is, the y-axis is median income It's essentially income gap. It's how far apart the top quintile is from the bottom quintile in earning capacity and disposable income. So in North Carolina, the income gap is nowhere near what it is in, let's say, Greece, for example. In Greece, the lowest quintile has far less purchasing power than it does in North Carolina. Let's go back. They would in fact be considered much poorer in terms of purchasing power, but they live longer than the poor in North Carolina. And that's now quite clear that this income gap notion is one of the simplest ways to measure risk for dying before your time. From something, from all-cause mortality, something. There are lots of theories about this, and I'm going to be talking to a number of them because they're relevant. But if you want to understand that collection of curves and the improvement in longevity over the 20th century, we ought to look at the structure of society. And we know that more and more from a number of other things. For example, do you know that longevity went down in Russia by about a decade within a decade of the fall of the Berlin Wall? And all of our usual risk factors didn't change. They couldn't drink any more than they were drinking, and they couldn't have a bigger gut-butt ratio than they had, and they couldn't eat more fatty foods than they were doing. It was something about the structure of their society, either that or migration patterns, people who had wealth left the country, but we don't think that explains it. By the way, let me pause for a second for an aside. All-cause mortality is a very powerful outcome measure. There's no debate about it. Disease-specific mortality is a much dicier outcome measure. Earlier in my career, I started to sign out the frail elderly's death certificate where they demand a cause of death, and I would sign it out as it was her time. And I would get angry phone calls from the bureaucracy in Raleigh saying, you can't do that. And I said, I sure can, I just did. I have no idea what the cause of death was. There are at least 6 processes that are vying for that role. If you want to choose one, fine. I don't want to choose it. Well, they would choose one, usually cardiovascular cause. So when you see outcome data, public health data about the epidemic of, say, heart disease, you ought to ask when they died, because you can't die in the United States of America or any place in Europe without a diagnosis. And a lot of the diagnosis speaks to these notions of all-cause mortality. It was his time, and the time was compressed because of socio-political issues in the environment in which this person was living. Can I have the next slide? The other take-home measure is the really dangerous notion of inductive reasoning when it comes to health outcomes. And this is one of my favorite. We've had a lot of fun with this slide. Do you know that in Bavaria, the population density of storks correlates at the microgeographic level almost perfectly with birth rate? Now, there's a lot of explanations for that, such as people nest under the ceiling and storks nest on top of it, but you can choose any one you want, and you can defend it pretty easily with these statistics. Let me have the next slide. And in terms of the stork model, let me show you how that's not irrelevant to what's going on with our data sets. These are the famous troubles with looking at observational data, observing something, and assuming you have the best insight onto how to explain it. I'm going to take a couple of these because they're worth talking about. For example, stage transition. For years, we've been talking about how much we've done for lung cancer and breast cancer mortality. We seem to be living longer. And part of the reason, if not the entire reason, until very recently was stage transition. Years ago, we used to define metastases by crude X-ray techniques. Today, we have all sorts of imaging techniques that pick up metastases. So things that would have been called non-metastatic cancer are now defined as metastatic. And they're living longer, not because they're what we're doing for these people, but because we picked up the disease earlier in its history. That's been called the Will Rogers effect because of Will Rogers' incredible sense of humor. He pointed out that when the Okies left Oklahoma for California, they raised the mean IQ of both states. That's stage transition. And then there's convenience sampling, and that was Berkson who first noticed that. Berkson was an epidemiologist working at the Mayo Clinic, and he started to realize that that patients who came to the Mayo Clinic by airplane were more likely to have more than one disease than people who walked in the front door. And that's Berkson's paradox. And the reason is you don't send straightforward cases to the Mayo from afar. You send the complicated patient, whereas the Minnesota Norwegian farmer doesn't go to the Mayo Clinic unless they're really in trouble. And they usually have just one thing that gets them there. So the reason it looks like multiple morbidities were becoming more and more frequent was Berkson's paradox. It was selection biases. And I can go through, in fact, there are books on this slide, and there should be. Observations are easy to make. Using that to understand causality is not easy, and it's loaded with pitfalls. Let me have the next slide. So we're going to see slides like this again. This is one of my favorite studies. It's an exceedingly important study that most people have not heard of. It's called the Whitehall study. It's Michael Marmot's work. It's a lifetime of work. Michael Marmot decided to follow the British bureaucracy, which is called Whitehall, named after the street where most of the buildings are. And he would follow them for decades. And most of the early work was looking for cardiovascular risk factors and correlating that with mortality, all-cause mortality and disease-specific mortality. And he ended up with these enormous, wonderfully sorted out data sets, all on his computer, all easily accessible. By the way, it turns out that for this population, the number one hazard for death, for earlier death, turned out to be a very simple question: do you like your job? If you said no to you, do you like your job, it cost you about 6-7 years of longevity. Now, nobody likes their job every day, but if you have that knot in your stomach when you get up, go to work in the morning, and we've looked into the reasons, and there are multiple reasons, and they all matter. The one I've worked on most is your boss is a fascist. That'll help you not like your job, but it has enormous health consequences. So here's this data sitting there and just begging for new questions to be asked of it. And this study was really neat. They took the Whitehall data set and they asked for whether or not, by the way, this data set was designed to look at issues in addiction, but it's still a data set of lots of people, all of whom are employed, all of whom are government employees, all of whom have health insurance, all of whom have access to health care, and just took a look at whether or not they could come up with a correlation with their zodiac sign. And if you go into a large data set looking for correlations, you will find them. They happen all the time. In fact, they happen with some reasonable statistical frequency. We usually set it at 5%, but it doesn't have to be at 5%. You could set it at any percent you want, you will find them. And what they learned is that if you were born a Capricorn, you were more likely to die sooner than if you were born Aquarius. Now that leads to no therapeutic in trials, it also leads to no sensible conclusion, except that mining large data sets for correlations is a guaranteed way to get fooled, just like this. And we'll be looking shortly at some large data set analyses that have led to conclusions that have public health ramifications that shouldn't be so. Let's have the next slide, please. So that explains the development, the trouble with induction and inductive reasoning that goes back to antiquity, led to a number of people to tackle the way you analyze data, that you need to do studies. You need to get deductive reasoning, you need to get evidence. And that's why really since the late 60s, evidence-based medicine has had a chance against eminence-based medicine, which is what determined almost all healthcare since the Greeks. Although I will tell you, having spent a fair amount of time in antiquity, that they were aware of that. Avicenna, in his textbook, which was the textbook of medicine for only 3 centuries, had randomized controlled trials and was very concerned about pharmaceuticals. And so was Maimonides, Rambam. And so are all the 20th century epistemologists. Again, there are lectures to be had on this little slide. I tend to feel most comfortable with the writings of Karl Popper. They were published when I was an undergraduate in college. And he's a refutationist, and in fact, developed the notion of refutationism. That means that anything you think is truth, even if it's evidence-based, is still a postulate waiting to be rejected. And that the truth of today is the hypothesis that has yet to be refuted. And it's sobering. It's very sobering. And it for those of us who actually go to the bedside and talk about what we can and can't do, realizing how tenuous our certainty is sobering. Richard Dahl and Bradford Hill. Bradford Hill, we had time for, is fascinating. He was an occupational physician who tried very hard to turn inferential reasoning into criteria. He actually never called them criteria for how you can do observational studies and end up with some chance of drawing a conclusion that's reproducible. It's not the answer compared to the randomized controlled trial, which came out of the Oxford group and which led to the understanding of the hazard in tobacco smoke, and which had an enormous impact. It allowed the FDA to go from worrying about purity and toxicity to worrying about efficacy. And that only happened in the 60s and 70s. It also allowed for a major change in the legal notion of truth when it comes to science in the courtroom. There's a phenomenon called the Daubert hearing based on a Supreme Court decision, which actually states that if there's a doubt about the scientific validity of something before the court, that the degree of evidentiary basis for opinions matters. It should be a simple issue now that we've come far enough to do deductive reasoning. Can I have the next slide, please? But as you might imagine, and as you know, even this simple notion has led to textbooks about the ways you can bend deductive reasoning with bias and prejudice in the studies and small effectology and self-interest and profit. Can I have the next slide? So here we have all of these randomized controlled trials now trying to deal with the uncertainties that are left when you do observational studies. I don't care how you do them, observational studies are hypothesis generating. Some of us have argued that there ought to be journals for observational studies that are entitled Observational Studies Are Hypothesis Generating, and here they are this month, because too many people actually don't realize how dicey that kind of inferential logic is. This shouldn't be dicey, the deductive reasoning. This should be a way through the murkiness. But there are ways to bend this so that it stays murky. You can prejudice trials. And in fact, I'm not sure you can get away without prejudicing trials. Who can do studies without having some prior notion of why you're doing them? Who would do a study on a drug or a vaccine or anything else without feeling in your heart of hearts that this is probably a good thing to do? And that's called equipoise, and it really matters because a lot of the outcomes that we look are not all-cause mortality. They're disease-specific mortality or morbidity symptoms. And how you measure them and how you elicit them all start with the very initial approach to the sampling and the permission slips and everything that goes into doing trials like this for people who are sick. That's not a trivial problem. And there's no way to avoid it. You just have to be aware of it. The imperious p-value. Fisher designed the 0.05 level because he was dealing with crops. He was dealing with agriculture. Imperious p-value of 0.05 is sort of interesting. I'm not sure 5 times out of 100 wouldn't be meaningful depending on what happens 5 times out of 100. In fact, if it's a trivial clinical event, I don't care how improbable it is by chance alone, it's still a trivial clinical event. So if you tell me that there's a little bit of difference in outcome, I'll tell you who cares. If you tell me there's a major difference in outcome, I'll tell you that I care and I want to explain that to my patient. And then we end up with all of this tremendous amount of data from these trials. And as with the Capricorn mortality study, it's very hard for statisticians and clinical investigators to see a data set without wanting to torture it. And if it was just sitting there, that's called secondary analysis. And as I explained with the Capricorn event, you can't do that. It's illogical. There's no way you can have any confidence that the result you sucked out of the data set is reproducible and meaningful. Let me have the next slide. These are all things that are common. I mean, I love to make rounds with the residents when they quote a meta-analysis, as if this came down from Mount Sinai as the 11th commandment. You don't do meta-analyses unless there's a lot of data that's inconsistent and not very compelling. The notion of a meta-analysis is that if you have a bunch of trials, none of which are that reproducible, that compelling, that interesting, but if you combine them together, like, and the usual analogy is chicken droppings. If you mix the chicken droppings, you can probably get chicken salad. No. For me, the meta-analysis saves a lot of work because if somebody is going to the trouble of doing one, it's much ado about too little for me to worry about in terms of clinical meaningful. Otherwise, we wouldn't need a meta-analysis. And then there's clinical significance. And we're going to look at a couple of trials in a second, and you'll see the difference between clinical significance and statistical significance. The FDA is hidebound on statistical significance. Reproducibility would be terrific, but some of these studies would take forever. And like all-cause mortality, it's very hard to do an all-cause mortality study and think you'll ever get tenure. These take a life course to do. So there's a whole set of maneuvers trying to draw something meaningful out of small effects. Let's have the next slide. Now I could do this with any one of a number, and I'm going to give you a list of things that I can do what I'm about to do, but I'm about to go after the cholesterol mafia. The cholesterol mafia goes back actually about 5 generations, and finally has managed to totally commandeer the common sense. And it's done it with trials like this and the next one we're going to look at. This is the famous West of Scotland trial. 6,000 Scottish men, presumably outbred and presumably willing to do this study. All of them had high risk for cardiovascular outcomes and a high cholesterol. And they were randomized to placebo versus one of the statins, pravastatin, and followed for 5 years. And what you learn is fascinating. First of all, there was no difference in death in the two groups. All-cause mortality or cardiovascular mortality didn't differ. It's also not so overweight. Most of these, in spite of the Framingham data and this tremendous number of ads you have on television, if you have a high cholesterol alone, and they tell you you've got cardiovascular risk, you're actually putting months at risk, not years of your life at risk with a high, so-called high cholesterol, unless you have familial hypercholesterolemia, a genetic disease that's rare and important. What they found was a small difference in non-fatal heart attacks. And there's the raw data for you. 6.5% of the placebo had a non-fatal heart attack during the course of 5 years versus 4.5% of the pravastatin control. And is that a meaningful difference? Well, how do you explain that? How do you think about it? You could say, you know, if I have 100 men with high risk for a heart attack based on what we know about risk profiles, and they take pravastatin for 5 years, maybe one will be spared, possibly two will be spared a non-fatal heart attack. Then some of them will get fatal heart attacks, but it didn't matter if they had pravastatin on board. And some of them will die of something else, but it didn't matter if they had pravastatin on. So that's the judgment on the part of the physician talking to the patient, and the judgment on the patient listening is, I've got to take this pill every day for 5 years. And maybe if I was one of 100 men taking this pill, maybe I'd be the lucky man. Now, we all love lotteries. And there's a lottery mentality that's driven by randomized controlled trials. Even this one, the lottery says, well, why not go for it? But that's not the way to think about it. Why don't you ask, what's the chance that I would not have a non-fatal heart attack? I wouldn't have a heart attack if I didn't buy the lottery ticket. And if you ask it that way, very few people would buy this lottery ticket because you can do as well without it. Let me show you how, let me have the next slide, please, how this plays out. This is the famous Jupiter study group. It's AstraZeneca. It's the trial that hit the New York Times before it hit the New England Journal of Medicine that made Crestor an incredibly lucrative drug for AstraZeneca. It's a multi-center trial. It was required not just a few centers, 1,300 centers in 26 countries. They screened 90,000 people for, not for a high cholesterol, but for a high C-reactive protein. The first author in this masthead had a series of papers, all of which are flawed, that C-reactive protein was a risk factor for heart attack. So this was what they thought of as a well people primary prevention trial of rosuvastatin to protect you from your first heart attack. And the reason it was in the New York Times was that last line here, that the trial was stopped early because of a 50% reduction in cardiac-related outcomes. That's called a relative reduction. If you ever see that, you want to know 50% reduction of what? Is it 100% fatal and only 50 died, or is it 1% fatal and 0.5% died? That's 50% too. A lot of us believe that no one should ever publish a relative reduction in the lay literature or the professional literature without the absolute reduction, because you're going to be making decisions based on this kind of information. AstraZeneca spent a fortune in direct-to-consumer advertising, like a couple of $100 million. We are one of two countries that allows direct-to-consumer advertising. All those ads that you see on TV, you won't see in all but one other country. We got hoisted up on our petard on that one too. It's like Citizen United. It was the notion that you have freedom of speech, even if you're torturing your speech so that you're fooling people. It doesn't matter. We can't squelch you. So the Jupiter trial gets published, and very few people step back and ask what did it really show, including the people on the masthead, all of whom are consultants to pharmaceutical firms. The consultants that's an interesting population, people who are brought in to consult. It inherently has a conflict of interest because you're being paid by the company that you're consulting on. But it was looked at by Congress for the FDA's advisory panel. Only one good study is done on that. And is it okay to be a consultant for the company whose drug is under consideration? And Congress said, yes, it is. So a study was done to see whether or not the consultants actually were prejudiced toward the drugs from the companies for which they consulted. And the answer is no, they're not. What they are is prejudice against the competition. And that's because these are not bad people. I actually, on that masthead, are two of my friends that I happen to know to be about as upright as it comes. But they're people. And you get involved in these trials and you say, hey, you know, not only they fly me to Monaco and gave me a great meal, but they gave me a lot of money to help them out, and they're really nice. Can I have the next slide? So here's what they found that allowed them to stop the trial early and publish it in the New York Times. By the way, stopping a randomized controlled trial early is illegitimate, illogical, irrational, and wrong. And the reason is these trials are all small effect trials, and the outcomes vary over time. There are times in the data analysis when the drug looks great, and there are times when it doesn't look so good, and it bounces around. And if you're waiting for the good time, then you're prejudicing your outcome. So if you stopped it early because all of a sudden this month or this 6 months or this interval, it looked terrific, can't do that. You can stop it early if it's toxic. So that's why you need to check on the results, so-called blind checks on the results, and during the course of the trial. But you can't stop it for a small effect, which is what they did here. And the small effect that they stopped it for was a combined endpoint. It was heart attacks and strokes and revascularization and hospitalization for angina or death from cardiovascular causes. Well, guess what? This drug, Crestor, did nothing to change the likelihood of death from cardiovascular causes. There were slight changes in the risk of a heart attack and in the risk of a stroke. The changes were so slight that if you gave this drug to 400 people in the case of heart attacks or 600 in the case of strokes for a long time, you might save one person. And that 50% reduction, that has to do with the rates of the primary endpoint, which largely related to hospitalization and revascularization, stents and bypass surgery. Now remember, there are 1,300 clinics here in a whole bunch of countries, and these are clinical judgments, and there's nothing uniform about it. So if we're not dealing with equipoise here that translates across countries, there's no way that those are meaningful statistical changes. So the Crestor had rates of primary endpoint of 0.7 and the placebo of 1.4, and that's your 50% reduction. And it had nothing to do with fatal heart attacks themselves, strokes. It had mainly to do with whether or not you were hospitalized and whether or not you had a stent. Can I have the next slide, please? And then they went so far as to do this in the New England Journal of Medicine. This is the cumulative incidence of the various endpoints. The first panel is the primary combined endpoint. The second panel is myocardial infarction. The fourth panel is all-cause mortality. And what they show you is in the all-cause mortality, in fact, look at any one of them. Those little lines that you didn't even realize were there at the bottom of the graph, that's the actual data. And that's why there's no important benefit of taking Crestor, a #1 drug, by the way. But if you blow it up, which is those little boxes, the graphs in the upper right-hand corner of each of the boxes, you can change the y-axis and expand the difference. And I can't believe that the New England Journal let them publish this, but they did, and they do things like this all the time. Next slide, please. Well, I picked on cholesterol. I could pick on a whole bunch of things. Here's a list of them, and I've written something like 20 books. The last 6 were trying to teach a sophisticated general audience how to deal with these data and how to read these data. The first of them was called The Last Well Person, which was designed for a discussion of medicalization. The second was Worried Sick. They're all trying to pick apart various parts of this talk. I've never attempted to put them all together in 1 hour. But this has very little to do with the improvement in longevity and nothing compared to the socio-political constraints on living out to a ripe old age. Can I have the next slide? And another bugaboo of mine that you live with all the time. Screening tests. What a great idea. Wouldn't we like to pick up your diseases before you knew about them and do something about them? And there are examples when we actually can do that, but not the ones that you hear about all the time. You have to ask, is the test accurate? get the same result if you do it twice and is actually measurable. Is the disease you're screening for important? There are some screening tests for diseases like hemochromatosis that are wonderfully important, but nobody is doing them because they're so rare. And if you have a positive screening test, can you do something about it? And when I take these on, and I do in a number of the books, what you learn is that this is a bizarre industry, despite data that says that the test is either not accurate or we can't do something about it, like minimal cognitive impairment screening tests. For that matter, colonoscopy. Colonoscopy is a very marginal test and no fun, particularly for the older you are. It's actually a dangerous preparation before you have the test. But whatever you can gain from colonoscopy, you can gain from flexible sigmoidoscopy, which looks at the terminal colon and actually will pick up early cancer there. And it isn't clear that, and doesn't require a lot of prep and doesn't require a lot of discomfort and doesn't require a whole bunch of things that that looking at your entire colon does. And it isn't clear at all that the increment in benefit can be justified, period. Let me have the next slide. And this is where you're all headed. This is where, as I've written more than once, artificial intelligence works very well for artificial patients. It does not work very well for most of the people who walk into the office. We've already talked about how easy it is to find big data sets, and we've already talked about how easy it is to massage the data. And we've already talked about how difficult it is to go into a big data set without your preconceptions and why it's exceedingly hard not to have prejudice, even if money and profit is not involved. The only good thing about large data set analyses is that you can do them in your office without any physical exertion. But otherwise, they are extremely demanding and need to be talked about in a very different light than we're hearing about them in the press. I usually talk a little bit about the morning prayer of the physician, but I'm going to give you a much more modern example of the morning prayer of the physician. Robert Hutchison was a pediatrician in the mid-20th century, died about 1980. And wrote his version as a letter to the editor of the British Medical Journal. And he said his morning prayer of the physician is from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. Let me have the next slide, please. So we started out with this imprecation, and I try to give some meat to it. I want to end with this cartoon. Next slide, please. Because what we're doing right now is getting rid of the one port in the storm people with illness might have, which is a trustworthy consultation. I think going to a practitioner is a consultation. And in the 21st century, no one should ever go before a doctor when they're uncertain and say, "Doc, what would you do?" That's a 20th century question. The 21st century question should be, "Doc, what would you do if you were me?" And that requires relationships and trust and time together. And that's what's going to be missing sorely in the near future if we don't have people like the program that you're all studying in now, educated about how you might interact with public policy and the public at large. because you understand more than what's marketed. Thank you. We have hopefully questions in the chat.